Welcome to the first WHO and Decide webinar on healthcare, public and private partnerships in low and middle income countries. My name is Gwen. I work at WHO HQ and I'm in charge of the Decide Health Decision Hub, which is the global network for value for money with a strong work stream on capital investment in health, contracting, optimization of asset management over the life cycles. So that tells you how delighted we are about WHO taking this timely step to publish that innovative policy brief on PPP in the healthcare sector. It's very timely because PPP is still a relatively controversial topic because it's the sort of old new kid on the block. It's been there for 30 years. Well, the concession models have been there for hundreds of years, but the new forms of PPP have been there for at least 30 years, but you still have strong, healthy debates and a lot of intel available, a lot of insights on PPPs on the one hand as contractual models, and a lot of intel and insight on health systems, but very rarely combining both. So for the first time, WHO, that dream team that I'm going to introduce, have managed to debunk the myth and propose a healthy systems perspective on the use of public and private partnerships. It's a dream team because they all are bringing different set of expertise, but they have used the health financing optic, which, to be honest, is quite rare in this area. So I'm very pleased to introduce my colleague Triin Habicht, who's the senior health economist sitting in the WHO Office for Health Financing in Barcelona, Spain. Dr. Mark Hellowell, senior lecturer at University of Edinburgh and the lead author of that groundbreaking policy brief that we all gathered to present today. Do I need to introduce Joe Kutzin, who's the head of health financing at WHO? I don't think so, Joe. And my colleague Ann-Lise Guisset, who's a hospital specialist and service delivery specialist and capital investment in health guru at WHO HQ as well. So with them, it's going to be a short webinar focusing on the presentation of that report. That's why we gathered here. But I've got four things to promise. The first thing is that at least you will gain clarity about this issue, where it's a bit like a national football coach. Everyone's got an opinion on PPP, but here you've got real specialists who know what they're talking about. And with their background in health economics, in procurement, in public law, you will have people who will bring you a different light on a complex contractual arrangement or set of arrangements. I can also promise that it's going to be a short webinar, but it's only the first one. So we're going to run a series of webinars. The next series will be panel discussions and interaction with the audience. So you will be able to engage with the panelists. This one is more to get to the bottom of that policy brief, because that's the excitement of the day. The third promise is that you can ask absolutely every question you want in the chat. So bring in all the questions. We promise you we will answer your questions in a blog. So the blog will be published on the Decide platform. It's decidehealth.world as soon as possible, but really bring it in. Snow us under questions and they will all be answered. The fourth promise is actually not a promise to the participants, but more to the panelists, that I will be a harsh timekeeper. So we'll try to keep it to an hour, which means I also need to get quicker to Triin, who will take the floor in a minute. Just the last couple of words. In order to frame that issue of PPP, it's hard to define PPP. You will have to go for, every international organization has a different definition of it, whether they're coming from a legal perspective, financing perspective, economics perspective, management perspective. Every legal system, national health system will have a different definition. So trying to come up with a neutral definition of a PPP, what we're talking about here are cooperative ventures between the public and the private sector, based on the expertise of each partner in order to respond to clearly defined public health needs through the right allocation of resources, risks, and rewards. That's as neutral as you can be. And if you look at it, if you pick from that definition the most important constitutive elements of public and private partnerships, you will get long-term arrangements because usually they're infrastructure related. So you need on average a minimum of 25 to 30 years to amortize an asset. You've got the risk sharing mechanism, whether the demand risk or whether the infrastructure, the asset linked risk, construction, cost overrun. Performance payments are linked to performance targets. The output-based specification is also an important point in the PPP area. You're trying to buy a solution here. You're not trying to buy a list of inputs like in traditional procurements. And perhaps another aspect is the asset ownership, which is different in PPPs. Asset ownership lies with a private partner rather than the public sector most of the time, which means that the public authority is actually buying a stream of services and not a capital goods, which entails, and Mark will shed a light on that, that on your balance sheet, you're not trying to amortize an asset. You do not have to, in terms of capital availability, it entails a lot of differences from traditional procurement, the fact that the public authority does not own the assets. And that's the off-the-book agenda, which also triggers a lot of controversy. Now, enough said, I'm very happy to open the floor to Triin, who will contextualize the production, the release of that policy brief with her health financing optic. Triin, floor is yours.
Thank you so much, Gwen, and hello to everyone. I'll be brief. I just want to provide some context why we, as a WHO, decided to develop this policy guidance, particularly focusing on middle-income countries in our European region. Most of the middle-income countries in our region require significant investments to replace or upgrade their existing health facility networks. And then in several of those countries, there is also major overcapacity and duplication, particularly in the hospital sector. At the same time, the public resources available are very limited to quickly address this investment gap, and it is a kind of major issue, and that's why ministries of finance and then ministries of health are considering different strategies for mobilizing the private sector to respond to this investment need. And of course, public-private partnerships are one option they are considering. And that's how the ministries of health usually end up seeking the WHO support and guidance, how to make the best decisions for their country's health system. For example, recently, Uzbekistan and Ukraine have been those countries where we have been more actively engaged. And what we really learned through this country-level work, that there is a knowledge gap in the health sector regarding what public-private partnerships actually are, what benefits public-private partnerships can actually bring, what risks are related and how to mitigate those risks, and what capacities ministries of health need to be put in place for successful public-private partnerships implementation. And that was the reason why we decided to commission this recently published policy paper. And we are truly thankful to Dr. Mark Hellowell for kindly authoring this report. And without any further ado, I will stop here and hand over to Mark to continue with the presentation. Thank you. Mark, you are muted.
I'm so sorry. So I'm hoping that you can now see my slides. Is that the case? Okay, so brilliant. So thank you very much for this opportunity. It's a real delight to present our report to all of you this morning, this afternoon. And I just want to give a little bit of background to the report to support what Triin was just saying. So one of the things we were concerned to do in this report is slightly shift the emphasis away from debates around, the value for money credentials of PPP, the very sort of microeconomic debate that takes place in much of the literature, and take a slightly different approach by, yes, recognizing that those issues are important, but they're not necessarily the issues that policymakers on the ground are actually faced with. So a representative minister of health, for instance, when they're thinking about the potential role for public-private partnerships within the context of thinking about, how can we address some of these capital investment requirements that we have in the healthcare system in the optimal way, yes, they're interested in the microeconomics of PPPs versus other ways of delivering capital assets and services, but they're also interested in other things as well. So they're also interested in, in the context of a lack of capital funds, in the context in which you can actually leverage public capital budgets, at least in the short term, by leveraging private capital. What is the opportunity there to increase the allocative efficiency and the financial sustainability of the healthcare system through using PPPs? And how can we organize ourselves to make sure that we optimize our approach, to make sure that if we are going to use PPPs, and there may often be, very strong pressure to do so, as we'll come to, then we do so in a way that actually increases technical efficiency, increases the sort of allocative efficiency, so we have the right assets in the right places, in the right distribution between primary care and hospital care and other forms of service domain, and we do so in a way that enhances the financial sustainability of the healthcare system moving forward. And so these are the issues which I think policymakers are very often concerned with. And so in this report, we tried to recognize that sort of fairly technical debates around microeconomic efficiency, value for money, these matter. It's necessary to get those things right. But there's also a broader issue about when PPPs are going to be used. What do we need to put in place to make sure that our approach is sensible and is going to help us fulfill our ultimate policy objectives? And so what are those ultimate policy objectives? Well, they're things like universal health coverage, making sure that all people can access the services they need. And that often means adding to the capital stock of the healthcare system, or perhaps reconfiguring the capital stock of the healthcare system. That's a process that needs to be service-led, so it needs to be underpinned. So the PPP process, the planning process, needs to be embedded within a sense of how services need to be reconfigured to maximize the potential of the healthcare system to meet population health need and other objectives around equity of access and financial protection and so forth. And PPPs really need to be seen as a tool for delivering on those things. And then we can look at the individual merits of PPP generically and individual PPP projects. But the main message of the report, I think, as I see it, is that we really need to be embedding that understanding of when to use PPP, how to use PPP within this strategic plan for how we want to deliver services, and therefore what kinds of capital assets we need. Okay, I'll push on, or at least I'll try to push on. Right, so how are we going to do that in the context of this presentation? So we're going to begin by lingering on this question of what are PPPs, because it's obviously a very nebulous term, and we want to try and clearly delineate what we're talking about here from other types of public-private contracting or other types of public-private relationship, so that we can be clear that we're talking about the same thing when we talk about PPPs. We need to understand how we might draw a distinction, for instance, between PPPs on the one hand, which are kind of the way that we're using the term here is kind of focused on transaction specific. PPPs very much focused on the production of capital assets and related services, on the other, in contrast to more sort of routine contracting arrangements that a strategic purchaser or an SHI agency might be utilizing on a more sort of institutionalized basis. Again, just making sure that we're clear on what we're actually talking about here. I'll provide a sort of a typology of different PPP models. It's not exhaustive, but I think it's representative of the PPP models that we most commonly see around the world, and especially in LMICs. And I think the articulation and the analysis of costs and benefits of those different models can be sort of generically applicable to the, let's say, 10% of PPPs that don't quite fit into that typology. I want to look at the main benefits, costs, and risks of these different models. And again, yes, we need to sort of look at the value for money credentials of these different models, but I also want to take a slightly broader perspective by thinking about, what are the key enabling factors, what key institutions and capacities need to be in place to make successful and effective use of these different PPP models. So what actions can governments take to optimize the use of PPPs? Once a decision has been taken to use PPPs in some form, how can governments make sure that they have in place the institutions, the resources, the capacities to be able to use PPPs in a way that, achieves their goals around UHC, around financial sustainability? Okay, so let's start with some definitions. So what are public-private partnerships? What do we mean by them in our report? What do we mean by them in this presentation and in this discussion? So one way to think about our focus here is we're focused on sort of transaction-specific PPPs. We're not talking about a wider range of relationships. These are not partnerships in a technical sense. They're contractually based. They're specific transactions. They're time-bound. And the sort of economic features of these PPPs is very much defined by the nature of the contract, by the contract and the procurement process through which that contract is established. We're talking about transactions which are typically very long term. So some of the smaller scale ones that we might be talking about, maybe they begin at five years in duration, sometimes 10 years. Some of the larger scale, more capital intensive PPPs can often run for several decades. So I guess there's a sort of common norm of around 30 years. And as Gwen said, you need a very extensive period of time like that because the capital investment needs to be amortized over a long period of time to make it affordable. And so you're typically looking at multi-decade contracts, sometimes 30 years, sometimes even more. Here in the UK, where I'm based, some of the first PPPs that we entered into ran for as long as 60 years. So despite the fact that they were signed in the early 1990s, they still have many, many years to run. So these can be very, very long-term transactions. Because the economic features of the PPP are defined by the contract, contracts are and need to be extremely detailed. So they can often run to many hundreds, in some cases many thousands of pages. A lot of transaction costs associated with establishing them. They need to set out very clearly the specifications of the public authority in relation to both the infrastructure they want, the capital assets they want, and the related services that they require. And they need to do that in a way that makes sense for them and will actually, reliably achieve intended outcomes. And they also need to try and do that for the full duration of the project, which, as I say, can be a sort of multi-generational thing in some cases. They need to set out clear performance criteria, KPIs, and also the associated payment mechanism. So the contracts are the kind of key regulatory instrument here. They create the incentive framework that will influence and to some degree determine the performance of the contractor in delivering the contract. So they tend to be, very intensive. They require lots of capacity, lots of specialist HR, lots of consultancy support typically to put these things in place to make sure that they're really robust and really comprehensive. Because as we'll discuss, any failure along those lines can really undermine and unpick the economic merits of these things. Payment by the public authority to the contractor is typically and largely determined by the availability of assets and services. So there's typically some element of volumetric-based payment, a volume-based payment, but that's typically rather modest. So as long as the private sector contractor is making these things available, both the infrastructure and the related services, they get paid. And they get paid on the basis that's set out in the KPIs and the associated payment mechanism. But essentially, they will get paid. The economics of the deal will work for them as long as they're confident that they can actually deliver the assets and deliver the services roughly along the lines of the specification in the contract. There is typically some element of volume-based payment, but that's usually small and usually not fundamentally important for the economics of the deal from the private sector perspective. A very important point to emphasize is that in terms of the sorts of PPPs that we're talking about here, most of the payment or all of the payment is going to come from the public authority concerned. So the payment to the private sector, which will remunerate them for their capital expenditure and their operational expenditure, and also provide them with a rate of return on their equity investment, and provide them with a source of funds that they can use to service their own debt. All of that comes from, generally speaking, the public authority. There may be some role for user fees, but typically that's fairly small. And so while upfront costs are borne by the private operator, the private sector entity that's delivering the project, PPPs do require a long-term commitment of public funds. So that's one reason why PPPs need to be considered from a health financing perspective, because from a public sector point of view, they are obliged to meet these long-term costs, and they can be very long-term, as I said, and they can also be a very significant call on the budget of the public authority involved. So these points 4 and 5 are quite critical. 5, because as I say, even though the upfront costs of investment are going to come from the private sector, the long-term costs will be borne by the public sector and perhaps some smaller element by the public, individual patients. Point 4 is also worth lingering on because, so from the private sector's point of view, all they need to know to ensure that the project is economically viable from their point of view and probably from their lender's point of view. So there's this concept of bankable. Is a project bankable? That means are senior lenders actually willing to invest the debt required by the private operator to deliver the capital investment? Well, all they need to know is that they're going to be capable of delivering the infrastructure and the related services along the lines set out by the contract, and that the public sector is going to pay the bill. So as long as they know those things, they know the deal, they can be pretty confident that the deal is going to be economic for them and will generate the kinds of returns that they're intending. They don't need to know that the deal is well focused, well targeted at the right services. They don't need to know that the deal has gone through this kind of, some kind of formal service delivery planning or strategic planning process. They don't care about any of that. As long as they can make the thing available and get paid for it, then the deal is economic from their point of view and bankable from their creditor's point of view. So this seems like an arcane point. It's possibly a bit more important than it seems, but it is crucial, because what it means is that a project can be bankable from the private sector's point of view, but actually the cost benefit from the public sector's point of view really doesn't stack up. So there is a difference between those two things that needs to be borne in mind. I'll come back to that point. Okay, so again, this may seem like a slightly arcane point, but I think it's useful, especially for those people involved in a health systems or a health financing world. It can be confusing. What are we talking about when we're talking about PPP? Should we care about this sort of arbitrary delineation between what is a PPP and what is some other form of public-private relationship? I think my response to that latter question is probably, it doesn't really matter. I mean, clearly PPP is a fairly nebulous concept, and how we apply that to particular contracting modalities is context specific and rather arbitrary. But on the other hand, it's quite important for us in the context of this presentation and in our report to be clear about what we're talking about, what we're not talking about. So, as I said initially, we're talking about sort of transaction-specific contracting arrangements, typically for a capital asset of some kind and related services. And so I would draw a distinction between PPPs that we're talking about today and the analysis of those, and more sort of routine contracting arrangements, whereby a strategic health insurance agency or some form of government purchasing agency is engaging with service providers, yes, the public sector, but commonly also including the private sector, in order to finance those service providers and enable them to provide services to the population on a subsidized or free basis. Right. Arguably, those are PPP arrangements. If you want to use the term, that seems to me okay, but it's not quite what we're talking about here. We're talking about transaction-specific PPPs, where you have a procurement process. So that the type of competition that's involved is competition for the market, for the contract, which takes place in some kind of competitive procurement process. And then there's a new business that's established on the basis of the contract. That might be a special purpose vehicle or some other kind of legal entity. And that business exists to deliver on the contract and to generate a return from it. Because these transaction-specific PPPs are very much based on the contract, as I mentioned, the contract needs to be really very detailed in all sorts of different respects, in terms of the specification of services, in terms of the KPIs and the related payment mechanism, in terms of the monitoring arrangements that are around the contract, so that the public sector can verify that it's actually getting the level of performance that it's paying for. All of that needs to be in the contract. If it's not in the contract, then it's not part of the regulatory system. And this is a little bit different from more routine contracting arrangements, where typically the sort of terms of trade, the basis on which service delivery is provided, is determined to some degree by a broader regulatory apparatus that may exist across all service providers. I think as well, one key difference is that typically with transaction-specific PPPs, patients are going to follow the money. You establish services, you establish capital assets and related services in a particular location, and you wouldn't expect those services to be in a competitive relationship with other rival providers necessarily in a particular locality. Whereas with more routine contracting arrangements, it's more likely that money follows the patient. There is, after contracts have been signed, still some kind of competitive dynamic in the market. And typically that's absent with PPPs, partly because of the nature of the services that are being delivered, but partly also to de-risk the project from a private sector perspective. And as I mentioned, you want to have a situation really, in order to balance risks appropriately, where the basis of payment to the private sector is based on availability and not their ability to attract demand. One reason for that is that most of the determinants of demand are outside of the scope of the private sector to really have a major influence on. Okay, so just another point which I think is worth making, because of some level of confusion about this that we see on the ground. So effective governance by a Ministry of Health, for example, does require an effective management of the PPP process at all levels of the state, from the centre through to local municipalities, for instance. So we want strong governance of PPPs, and Ministries of Health will typically play an important role in exerting influence across the programme. But having strong governance of PPPs is not a substitute for having strong governance of the health system more generally, and the private sector in particular. And I mention this, it seems kind of an obvious point in some ways, but there is sometimes a tendency of governments to say, okay, well, we recognise there's a private sector and we need to strengthen our sort of governance apparatus, our governance regime. But we have a PPP program now, and we have a PPP unit, and it's staffed by people who are specifically assigned to look at this program and to make sure it's managed appropriately. And I think my sense is that it's quite important to be able to say, well, okay, you're doing that, but the sorts of tasks that that unit will perform and the sorts of outcomes that that program will deliver are very different to the sorts of tasks that you would want to employ in order to make sure you have proper governance of the health system and the private sector in the health system in particular. So it should, I think, be seen as a core task of a Ministry of Health and government more generally to establish a robust governance regime for the private sector with, strong legislative framework, robust regulatory apparatus, integration of the private sector into routine information collection, inclusion of the private sector in terms of policy dialogue structures, having that framed within a very robust policy and vision that includes the private sector. All of that needs to be done and needs to be seen as a core function within the Ministry of Health. All of those things are kind of orthogonal to what we're talking about here, which is the effective governance of capital procurement and PPPs more generally. So having a PPP unit is not the same as having strong governance. Having a PPP program is not the same as having an effective private sector engagement policy. It may be one aspect of that, one element of that, but it's not comprehensive. Okay, I suspect I need to speed up a little bit. So let me just very briefly say something about the kinds of models of PPP that we focused on in the report and that are occupying our attention here. So essentially there are different sorts of capital assets that are associated with different models. So model 1 here on this slide, we're focusing on specialized clinical or diagnostic services and associated capital assets. And this is a fairly commonly used model in key sort of areas. Hemodialysis would be one kind of quite prominent example that we see. And this is a model in which the public sector identifies specialist services in which there is a gap in delivery and engage with the private operator. The private operator will normally finance the upfront capital costs, so new equipment, new premises, and then payment to the operator is made by government on the basis of an annual per capita or per treatment model or some kind of combination of the two. And in some cases, they build in opportunity for users, co-payments as well. A second model is what we, here in the UK, we used to call a PFI model, which more technically is known as the Design, Build, Finance and Operate model, the DBFO model. And this is where the private operator manages the design, build, financing and operation of health facilities. And this is much more infrastructure based, tends to involve less service delivery. The service delivery that's included tends to be those which are most proximate to the infrastructure. So, auxiliary services around the infrastructure, cleaning, catering, this kind of thing, but stopping short of core clinical services. And then Model 3 is, in some sense, a combination of Model 1 and Model 2 in that it has a kind of DBFO framework and includes the full range of services and activities in Model 2. But in addition to that, core clinical services are included as well. Sometimes this model is much less common. Sometimes this model has been used as, or has at least been considered as a way of creating scope for the inclusion of payment by users. So this would make it a more sort of conventional concession-based type instrument. We haven't seen too many examples of that in the real world, but it is on the books, as it were, when ministries of health and PPP units are thinking about using PPP in health. They're sometimes quite interested in looking at ways of, yes, encouraging private capital into the system, but potentially also creating an instrument through which they can increase private financing. So I'm not going to focus on that too much in what follows, because we're not seeing any real activity along those lines on the ground, but I think it's worth just recording that we are seeing some discussions around this in specific contexts. So here's what we're looking at: transaction-based PPPs, sometimes for equipment and premises, sometimes for larger scale facilities, often hospitals, and similar structures in terms of opportunities and challenges, similar attributes in terms of those things, but with some differences at the margin. When we look at Model 1, sometimes there's a parallel interest alongside the production of new capital assets and services. Sometimes, as we saw actually here in England, there's also this idea of using this instrument to bring a diversity of different private sector actors into the health system and enable that through guaranteed public financing. So creating a new market, in effect, for publicly funded services. Whereas with Model 2, you're normally primarily driven by the ability of the private sector to increase your capital budget, provide a superficial relaxation of the capital budget, and therefore allow more capital investment to take place than would otherwise be possible. All right, so hopefully I've defined the terrain reasonably clearly, so we know what we're talking about, and now we can move from the sort of descriptive to the more analytical, the more kind of evaluative. And I'll begin by a sort of fairly conventional analysis of value for money, and then I'll move on to a form of analysis which I think potentially is a little bit more relevant from a health systems perspective. So this is relevant, this is important, but it's not sufficient, I think, for us to really understand what to do about PPPs. Okay, so the sort of conventional case in terms of technical efficiency at the project level for using a PPP would be something like this. Okay, so PPPs have certain economic features, and that combination of economic features can sometimes, given certain enabling factors, address specific problems with more conventional forms of procurement, and that can in turn lead to outcomes which are intended and which are desirable in terms of minimizing costs and enhancing technical efficiency. So just very briefly, let's look at these economic features. So with a PPP, unlike sort of traditional conventional procurement, you sign a contract with a private operator, and through that contract, they are required to perform a whole combination, a large combination of different activities. So they design the hospital, let's say, they build the hospital, they finance the capital expenditure requirement. Once they've got the thing built, they have to operate that infrastructure. They may have to deliver certain types of services within it. And they need to make sure that through all of that, whatever money they're getting from the public sector and users is going to be sufficient to remunerate their capex, their opex, and provide them with a return on capital. So in theory, they have an incentive to bring those things together in an efficient way, in a way that's very difficult to do through conventional procurement. And the overall technical efficiency of the product, this combination of assets and services, may be more efficient than would be obtainable through a conventional procurement, where that bundling process is not possible, whereby you're contracting separately for these different things. By internalizing these costs, it's possible that they're able to take advantage of economies of scope, bring these things together in a different way, and thereby deliver in a more technically efficient way. However, they're only going to be incentivized to actually share the benefits of that with the public authority if there's a fully competitive procurement process. Otherwise, they can just internalize the benefits of that through a higher profit margin. But if there's a competitive market during the procurement process, then that's going to exert some downward pressure on prices. And so, in theory, the benefits that they obtain through taking advantage of these economies of scale is going to be captured to at least some degree by the public authority. Secondly, the benefits of risk transfer are really fundamental here. So the contract ought to provide a very strong incentive for the private sector to essentially deliver at the level of performance that's required at a low cost. And if the contract is well defined, legally enforceable, and performance is well monitored, then that financial incentive framework that's been put in place by the contract ought to really be influencing behavior, ought to be really influencing activity. And what that can mean is that even if the private sector is unable to manage the construction project efficiently, it has cost overruns, or it's unable to deliver the level of availability that's required by the public authority, it bears the cost of that. There's no additional funding from the public sector. It's a fixed price contract, so they have the incentive to deliver at the cost that they were expecting at the time that contracts were signed. If they fail to do that, that is their problem, and they are exposed to financial losses. So this combination of economies of scope, risk transfer, which creates this financial incentive, and a competitive procurement might help us to ameliorate some of the sort of classic problems of public procurement around, adverse selection in terms of selecting the wrong projects, the wrong designs, the wrong contractors, and also moral hazard, whereby, a private sector provider or construction company quotes a price, but then when it realizes that it can't deliver on the basis of that price and it's making financial losses, they come back to you and ask for more money. Well, that shouldn't happen with PPP, so that can deal with adverse selection and moral hazard problems. However, this is dependent on there being all sorts of enabling factors in place. So the public sector needs to have really strong capacity. It needs to be able to specify what it wants in a legally enforceable contract and actually verify that it's getting what it wants over the duration of that contract. So it needs really robust monitoring arrangements, as well as really good specialist HR to be able to write the contract appropriately and then enforce that. Now, do those things exist in practice? The answer to that will be context specific, but we know that in practice those things are absent or inadequate in many real-world contexts. If those things are not there, I think it's important to note that these are necessary conditions for the sort of intended outcomes on the right-hand side of this slide to be delivered. If you can't write a good, complete, more or less complete contract, and it's not legally enforceable, and it's not operationally relevant, or you don't have good, strong monitoring arrangements in place to verify that you're actually getting what you're paying for, then these outcomes on the right-hand side are all at risk, and one might argue unlikely to be realized. All right. So
I'm sorry. I'm loath to interrupt you because it's really extremely interesting. It's 31 minutes in.
Okay. I will wrap up as I will be much more efficient from here on in. However, I would just like to draw attention to this sort of broader perspective, which is, I think, quite relevant to a sort of representative Ministry of Health that essentially has been, is under strong pressure from a Ministry of Finance or some other powerful agency within government to leverage its capital budget by using private financing, and it wants to invest in new capacity, or it wants to reconfigure its existing capacity to optimize the performance of the healthcare system. So what sort of costs and benefits does PPP offer a Ministry of Health that's in that situation? And many ministries of health are in that situation. Okay, well, PPPs, as we're talking about them here, they involve private capital financing that tends to be off balance sheet, off the books, from a perspective of government budgetary reporting systems. And that gives you this, could be argued superficial, but it gives you this relaxation of your budget constraint. It allows, in the short term, more capital assets to be delivered, or more capital investment to be delivered. And this can be beneficial, right? I mean, it can carry risks, but it can be beneficial potentially, because if certain things are in place, that means that, and I've called these enabling factors here, and this kind of funnel metaphor, which is depicted in the slide here, these enabling factors or these filters need to be in place for that potential benefit to be realized in practice and at limited risk to the sustainability of the healthcare system. So if PPPs are embedded within a really strong service delivery vision, a really strong strategic plan through which the required assets associated with that vision are clearly defined, such that we begin with that question: what services do we want? Where do we want them? How can we provide them in the most efficient way? What is our level of budget to be able to deliver on that vision? And what else do we need? And where might capital financing play a role, private capital financing? Then perhaps PPPs can be optimized. That also needs to be underpinned by really clear fiscal planning. So having a long-term perspective about what's going to be affordable, and having institutions that actually require that, you know, unaffordable schemes or potentially unaffordable schemes are not taken forward. That potentially needs to be underpinned by the involvement of auditors, parliamentary auditors, supreme audit agencies, those sorts of entities, to really check that this the plans are actually going to be affordable and are not going to undermine the capacity of the health system to deliver going forward. And obviously, more generally, you need the capacity to implement. You need all of those capacities which I just described in that previous slide to implement successfully. And if these enabling factors are in place, and only if they are in place, then could you make a feasible argument that PPPs can enhance allocative efficiency at the system level?
Mark,
Okay.
I think we need to. We've got 15 minutes left, 40 minutes left. So if we could just wrap up so that.
Yeah. I will do that. So I think the point of this slide here is just, in the absence of these things, we've got a real moral hazard problem which self-interested policymakers or politicians may respond to. It's like, okay, my budget has now gone from being very constrained to potentially very large, and you know, one can go ahead and sign off as many PPPs as one wants, but without those sort of filters, then there's no guarantee, and in fact there's a strong possibility that these things will not be optimal from a health system perspective, and that might actually undermine the ability of the health system to deliver. All right, so key policy lessons: getting the question right. So we want strong health systems, we want UHC. What is the role of capital investment within that? What is the role of PPPs within our capital investment strategic plan? That's the right place to start. That's the right sequence of questions to try and address. Yes, building internal capacity to do the implementation, also building the internal capacity to do the strategic planning appropriately, underpinning that with really good systems of scrutiny and independent challenge to make sure that the public interest is going to be advanced by these things and not undermined. And quite separate to all of that, continue to focus on this overarching challenge of making sure that you have a robust public policy framework in place for governance and regulation of the wider private sector. Purchasing, regulation, legislation, information gathering, policy dialogue. These are things that need to be in place. They're not quite the same thing as having an effective PPP program in place. All right. Apologies that I ran on, and I'll hand over at this point.
No need to apologize. It was extremely interesting. I think everyone was drawn to that presentation. It triggers 100 of questions. I've got 100 of questions. We do have questions in the chat, and again, they will be answered in a blog. But thanks very much, Mark, for managing to synthesize a wealth of information, which again has never been produced before. Joe Kutzin is here also to give us probably a broader scope and a contextualization of the global health financing landscape and challenges. And what's going to be challenging for Joe is that we now have 10 minutes left. I think we're going to be a little bit over time, but Joe.
Okay, well, part of the global health financing perspective is we don't believe in budget constraints like time, so we'll deal with it. I think that for me, and thanks to Mark for this, is really important, and it has been, I think, for health financing and certainly my own work, basically an area we haven't touched on. And I think what I want to talk about in these few minutes is really to think through the whole issue of investment. Okay, now I have a lot of concerns with how that word has been used lately. Like a lot of words, it's come up very loosely. We hear it often now in this rhetoric, which per se is not a problem, where we say health is an investment, not an expenditure. And that is political language. It's driven by an understanding that there's health gain, which has intrinsic value and also contributes to longer term development. But it doesn't have any meaning from a kind of in a budgetary sense, right? Governments have capital investment spending, they have recurrent spending. And so what we're going to try to do, or what I'll try to do, is move very much to this kind of practical budgetary issue. Perhaps the most important thing that Mark said, which I would reemphasize, is getting the question right. matters a lot, right? And so oftentimes these things have come up because the objective is how do we do PPPs, or how do we promote the private sector's role, rather than how do we move towards UHC, right? So this confusion of ends and means has had some really negative effects in some places. And as I said, for us in our health financing work, capital is invisible in a way. So when I talk about revenue raising, pooling, purchasing, benefits, capital investment isn't really there. And this is increasingly problematic. And so to respond to all of these things, we need to kind of bring some conceptual clarity to this discussion and these issues, just as we think we've done with recurrent finance. What I'm going to say is maybe more of a pre-framework or something that's in the early gestation period. So it needs some criticism and feedback. But just to think about health spending and public and private roles. First category is really what we generally talk about in health financing, which is recurrent spending. And there, basically, private sources means out-of-pocket spending and voluntary health insurance. So Mark referred to co-payments coming up a lot in some of these examples. So our position on that is very clear, strongly backed. We're not going to say, I won't say much about it here, but basically that, growth of out-of-pocket spending and voluntary health insurance is generally not good for UHC. Second is what Mark talked about, which is capital investment for the health delivery system infrastructure. So things like hospitals, health centers, equipment, diagnostic centers, and so on. And it is something of uncharted territory, at least for me, in terms of thinking about how this relates to UHC goals. And so I'm trying to think it through from a common sense perspective, and also really building on some of the things that Mark said. So if you have a situation where you've got rural underserved areas and there's an important need, given the goal of UHC, to extend services there, then there's a rationale for doing some investment in that area. Any government would then need to think through, before you go ahead, you have to do the analysis of what will be the incremental recurrent cost implications of that and come up with a plan for it, whether it's a larger share of the budget or something over time, like with a World Bank loan or something like this, where you're thinking of longer term growth and the ability to increase public financing of health. What you want to avoid is setting something up that's going to have to be funded out of user fees, or imagine that there's going to be some community prepayment scheme that will magically come into life. So what does it mean for private capital here? And I think the issue is that we have the same criteria. You need to be able to fund the recurrent cost and maybe, that incremental debt. And the question is, what is the rationale for a government to then pay a private return to investors on top of that additional recurrent funding requirements? And I mean, conceptually, that would have to do with whether those returns are more or less than the incremental debt service, let's say on a traditional development project. Of course, if you have a grant, then you're in much better shape. But largely speaking, there is a real concern if this starts to generate a push towards more user co-payments and thinking about the incentives that it brings to private operators. So in practice, we do see a lot of private investment in these things in hospitals and diagnostic centers. But again, this is not driven by UHC. And this is a question maybe more for the IFC and other agencies that support them, which is, what would it take to reorient the objectives there towards UHC in a way for simply private sector promotion? Last thing I'll say very quickly, where I do think there is some scope for this expression, private return seeking capital, is another category of investment that's become much higher on everyone's awareness in the last few years, which is capital investment for the production of health inputs. So basically medicines, vaccines, PPE, surgical supplies. Now, this is different than infrastructure, because any good health system has to buy those inputs, has to have those inputs to run, if they're serious about UHC, right? And as things being produced, somebody has to buy them, which means there's a market. And so there is a scope. If governments do a very good job in those capacities that Mark referred to in terms of being able to negotiate price and distribution, there is still presumably some scope for a reasonable profit, whatever that means, something less than what Moderna and Pfizer got, let's say, right? And that government takes quite seriously this need to be very strong on price and distribution. So here is where there may be some scope for very well-governed private investment, but it's very much in the inputs scope. So why I raise all of that is because there's a lot of desperation that comes out periodically in health finance, huge gap, and so on. And acting out of desperation is not a good idea. So my aim is to say, how do we get that energy for private investment into the right box, which for me is that third category? And having done that, where do we focus our assistance? And that is in terms of really helping governments strengthen their capacities to make a good deal in terms of price and distribution. And that very much speaks to Mark's points. But we do have a very long way to go. And the main thing I see from all of the conditions that Mark laid out is to reinforce, I think, the view that we should not believe in magic. We don't go chasing things because we have a gap and because we're desperate. So we need to really proceed in a more systematic way, relying on this kind of clear framing that Mark gave about all of these conditions that need to be met before going down this road. Thanks.
Thanks so very much, Joe, for the wise words, but also the different perspective that you bring, which will no doubt contribute to a lot of conversations probably in the next series of webinar. I'm turning that to Ann-Lise, because Ann-Lise, you're part of the Decide Capital Investment in Health group, and you're also in charge at WHO, more specifically, of CIH to feed into the policy dialogue with governments. And I'm just wondering, from your experience, how does the complex contractual arrangements, the PPP agenda, which is a very specific agenda, how does that fit in the much broader capital investment in health, bearing in mind that we're all WHO here, so we on the panel, except you, Mark, but you still have your WHO as well. But the question is, we all know that according the SDG realization means the second cost driver of SDG realization are infrastructure, investment in capital goods. So that we need to fill that infrastructure gap. Are PPPs not a magic bullet, not the magic solution that Joe was referring to, but is it an important part of the CIH agenda that you know so well?
Thank you very much. And really, what I had prepared as interventions is very, very well linked with what you, Gwen, what Mark also said as an introduction, and again as conclusion, that this is a solution, and this is a tool to deliver on policy objectives. So really, PPP will be as good as it contributes to those policy objectives. It's really just an instrument to get where we want. And so this will be really important to have this very clear strategic vision on what do we actually want to achieve, and how can capital asset investment serve as a catalyst, a facilitator. Because right now, we often hear that those are a legacy, and it's a legacy that makes the transformation of the health system very difficult to achieve. It is so, how can we make the capital asset investment not be anymore a legacy, but really a facilitator, so that they become catalysts for transformation now and again in the future. So with regards to this, I just want to think, most of the PPPs and the large-scale investment will be around hospitals. And in the health sector, hospital sector, generally speaking, we have seen for 30 years, in the last years, we have talked about restructuring of the sector. And very much those master plans were about doing more, scaling up or scaling down. So doing more, doing better, or doing more efficiently, without really questioning what do we really actually want to do. On this agenda, we have in the last five years, I would say 10 years, started with a transformation agenda, really thinking the old approach has not worked if we don't have integrated health services, if we don't focus more on prevention, promotion, if we don't fix a fragmented system, then we are going to continue to lose in inefficiencies, in waste in the system. And so this restructuring agenda, or doing more and doing better, has been completed with a transformation agenda. And in the last 3 years, after the trauma of the COVID crisis, we are really now we need to create a healing environment to heal from this trauma. And so the question really is, now when we think the health system reforms, when we think about the different tools that we have in our hands, will the PPPs be able to bring this transformative approach, and also will they be also sufficiently fine or tuned to also heal and think about the people who are in the system, because the people in the system that are making the system work, they are at breaking point. So what does it mean to work in a facility that has been structured around the PPP? I would just like to quickly, because I know we are above time, think about the one key, the functions of the hospitals, where most of the PPPs will go. The functions, of course, will be to timely deliver inpatient, outpatient services for the patients that require 24 hours, 7 days, acute time-sensitive care with high technologies and so on. And for those, we can set some level of activities of output with the PPPs. But the hospitals, being organizational entity that concentrates care resources, also have a key role to play in minimizing the impact of public health emergencies and humanitarian crises. So in a contractual arrangement, like we say PPP, how can we integrate this element of risk, not financial risk, but really this we don't know if an emergency will happen, but how can we add this function of minimizing the impact of emergencies? And then there are also some important functions that are now added for hospitals. Because if we think about not just the performance of the facility of the organization, but the performance of the system, and if we want the system to be reoriented towards primary health care, we need hospitals to deliver services not to their patients, but to the other part of the health system, so that the other part of the health system work well. They can complement and amplify the effectiveness of other healthcare providers. They can also be a setting for education, training, and research. So how do you integrate those services that are not services directly to the patients, but services so that the patients can be treated well, for instance, in primary healthcare? How would you integrate those volumes, those different kinds of function into your PPP contracts? And then finally, hospitals will need to recognize that there are social and economic actors. They have an incredible socio-economic impact in their local communities through decent working conditions, mainly women, hiring women, local purchasing, sharing utilities, and they also give a sense of security and pride to local community. We are not talking about the societal functions, or we are talking about hospitals as anchor institutions. How can we ensure that hospitals in PPP contracts are not driven by cost efficiency, but are also driven by these values of leading by example, of supporting the local development, and don't have this. So that's also a point that I wanted to raise. Will be important when those contracts are being done, to not only think about one function of the hospital, but to look at what hospitals will have to do in order to strengthen the system as a whole. And then finally, I just want to quickly highlight the importance of the capabilities that also capacities or capabilities that also Joe referred to for the strategic planning of capital assets. we have done a review of the literature and a number of interviews with Jonathan Erskine and Grant Mills, and we have really realized the difficulties of the Ministry of Health and the people who will engage with Ministry of Finance, with bilateral donors, with the banks, and so on. We have seen that they have limited capacities to engage in those discussions, and so even less to engage in a really very difficult governance of PPP. And so really the importance of strengthening these capacities, first for the strategic planning of capital assets investment, and then also to have the tools in order to engage in those PPPs. Thank you.
Thanks so very much, Ann-Lise. That's broadening the scope of and the perspective on capital investment in health. I think we can all agree that, and that's going to be a part of the quick conclusion, that one of the key factors to get the PPP right, if that's an option versus traditional procurement, is does the public sector have the capacity? Do we have in-house capability to manage long-term projects over the life cycle, given the turnover, given the high level of expertise needed? Is that the right choice? Is that in terms of capital commitment, in terms of buying that stream of services and checking that they deliver performance? It's the question of capabilities. I remember talking to a hospital director working for the World Bank and saying, those PPPs are so complex that I believe if the public sector can genuinely understand them and manage them, they probably don't need the private sector anymore. And that's a bit of fuel for thought somehow. I would like to thank you all so very much, but I'm going to come back to thank you because you brought so much expertise, so much experience. You've helped, I believe, disambiguate PPPs from traditional procurement. You thank Mark for sort of, it's a stepping stone. It's not about private sector participation. And I got a lot of feedback from people saying, well, we worry about private sector participation. Private sector participation is granted. With traditional procurement, you will have the private sector putting the bricks and layer and building your assets anyway. This is different. This is complex contractual arrangements. And as you all mentioned, it's about having the availability of an asset and related services, mostly ancillary services. It doesn't even have to be the whole asset. It could be, I think 10 years ago, a third of the PPPs in the hospital sector in France were all about energy performance. So how do you transform your fuel consumption and environmental norms so that you comply with new norms that apply to all public buildings? That's what you said, Ann-Lise. PPPs, how do they relate to economic and social diversification? Sometimes environmental performance, sometimes gender empowerment. But we have to be clear about that notion of PPPs, what are they for, what they can deliver. They're not about project finance. I think it's also important to emphasize that PFI, as you mentioned, Mark, was an investment program. Private finance initiative doesn't mean that a PPP as a complex arrangement has to tap into private finance. In preparation for that webinar, we discussed the recently advertised Melton project in Australia, and the state of Victoria is extremely innovative in the way they use PPPs. Melton is 900 million Australian dollars, so approximately 700 million dollars, American dollars, and that's all coming from the public purse. So that's a choice. That's a conscious choice of the state of Victoria that instead of going for the private capital leverage on the market at a higher interest rate, that's what the public sector can usually leverage. Why not use the capital that's the capital expenditure available from the public sector? I think we haven't delved enough on the competitive dialogue, which is supposed to bring in terms of procurement processes, innovation and performance. But that's probably something for the next time. We've got so many topics that we need to, that will branch out for that fantastic report, whether the refinancing, the third-party revenue generation, the public sector comparator to assess the potential cost effectiveness that can be delivered from a project. The myriad of projects. Mark, you mentioned DBFOM, and I think it's fair to say that there's actually an alphabet soup of models. And on this webinar, we've got people like Oksana Bovskaya from EPOS. We've got Pascal Garel from HOPE, who's also a board member of Decide. We've got Thomas Kergal from the Council of Europe Development Bank, who's also a board member. Their bread and butter is to play with these models. It could be a boot, build, own, operate, transfer, O&M, operate, and maintain. The PPPs is a flexible agenda, which is probably a part of its attractiveness as well. And that's something that we will have to discuss in the next series of webinar, which is coming. And you'll all be part of that, including you, Joe. We've got at least 7 or 8 questions, which again, we'll capture and respond to in a blog because we're way over time. But really, I would like to thank all of you in the name of all of the participants for this quite innovative webinar on the health system and the use of PPPs. It has a resonance for Decide because, as you know, we work on CIH and PPPs and the larger contracting agenda. And I thank you very truthfully for the wealth of insights, intel, and excellent ideas you've brought on the occasion of the launch of that report. Triin, you've been kind enough to say that we can find on the WHO website the policy brief. If you go on decidehealth.world, we also give the link to the WHO website where you can download that report. The only advice left is really do not miss it. Read that report, and that will trigger, sleepless nights full of ideas about how to use PPP and what to do, what not to do with them. Thanks so very much again. And with that, we will close our first webinar on Healthcare PPP. Many thanks. Have a good day. Bye-bye.
Thank you.
Thank you.
Bye-bye. Thank you. Have a
Bye-bye.
good day.